Okay. Everybody ready? What a day we have today. Whoa, what a day. What a day. Oh boy, oh boy, oh boy. I'm super excited. Oh boy, oh boy. Because we're going to hear from one of the consumers of people who work on this technology, which is a radiologist. The other consumers are, of course, patients. But other type of consumers are radiologists, and we're going to hear later, like maybe in about 20 minutes or so. Again, any announcement?
Yeah, the homework is due tonight, so make sure to submit that. And I posted a sign up for lab next week, and I think most people already did, but make sure you do that too. And yeah, get excited for next week, I guess.
Oh, what a lab. What a lab. Oh, what a lab. Oh boy, so much fun, so much fun. We spent hours on the scanner trying to debug that lab. And eventually we're able to come up with some nice experience for you. So yeah, hopefully you'll enjoy it. The lab is about pretty much imaging. So you're going to prescribe, sequences for, on a clinical scanner. You see the user interface. You'll set parameters, change, field of view, resolution, TR, bandwidth. Look at the noise. What happens when you change the resolution. How you can gain back the noise by averaging, or all sorts of other tricks. And then also look at contrast. So lovely. And at the end, you're going to eliminate a tissue with inversion recovery. Eliminate. Tissue will die. All right, any questions? And I believe that, Ekin, we said that we will let people get scanned if they want to.
Yeah, so, right. So if anyone wants to actually get scanned, then they can contact me like after the lab, and we'll schedule some time for a short one, but still.
Yeah.
It'll be nice. Yeah.
No more than a couple hours.
Yeah.
And
At
if you want to
most 3.
volunteer also, if you also want to volunteer for an experiment, you're more than welcome. Right, Ekin?
Yeah, I'm always looking for volunteers, so.
There you go. Yeah, all right. So any questions or things before we start? There's a few things I want to finish before Shreyas comes in. No? Okay, fine. I can be cathartic too. It's like, oh, okay. Yeah, well, today we're going to talk about volumetric imaging. That includes multi-slice, RF, encoding, and then 3D Fourier encoding. Okay. So let's talk about multi-slice. Multi-slice is when you excite each slice and then you image it. Hadamard encoding is when you encode it with Hadamard. And 3D is when you do a 3D encoding. And that provides a little bit benefit. And that's the result. All right, cool. All right, now for real. All right, multi-slice. So we talked about multi-slice. And The way multi-slice is done is basically we saw that if we just image one slice, slice selective, we have RF excitation. Slice select, kind of what the rewinder now does, exciting, then phasing code, and then the readout. And then often you have to wait a significant amount of time. For example, if you wanted to do T2 weighted imaging or proton density, you'll have to wait quite a bit till the tissue recovers, and then you are going to excite the next phasing code. So you do this one, and then you wait TR, and then you do another time, and so on and so forth. And then if you wanted to do another slice, that will take you a significant amount of time again, like you have to repeat that over and over again. But instead, because you're only exciting one slice, while this slice is being recovered, while the slice is recovering, you could potentially excite a different slice and then image that one because it doesn't have to interact. And so we talked about that. That basically increases the throughput. And the idea is that you excite slice one, you collect one phasing code, of course, you crush the magnetization, and then you excite, let's say, slice three, encode the same phasing code, and then slice two, slice four. And so you don't want to have the slices too close to each other because of the leakage of the RF. Remember that RF is, it's selective, but it's not as selective as we would like to. And having more selective RF pulses also results in more power that you need to dissipate. So the higher the time bandwidth the RF is, hence also the power. So that's something that you have to be aware of. So what you do then is after you excite so within the time that you have, you say, okay, well, I want a TR to be, I don't know, 3 seconds or so, 2 seconds. Well, I can squeeze in a lot of slices during that particular time. And then the way to do it is, you excite slice 1, 3, 2, 4, acquire a phasing code, and then you repeat 1, 3, 2, 4 again with a second phasing code, and then another phasing code, and another phasing code. Now, the cool thing is that often the slice actually has enough time to recover fully. And once it recovers fully, it means that your SNR is going to be high. You're not going to be limited by, the recovery time that is typical. You're not limited by by this time of the excitation. Really, it's the time from here to here that allows you to fully recover. So that improves the SNR because of that. Now, it does. So the thing is, this improves the I guess the throughput, so you can squeeze more slices within the same amount of time, but it doesn't change the SNR efficiency. Okay, the SNR really is not, doesn't change. Okay, you get more slices, but the SNR is not improved. It's exactly the same as if we were just to collect, a single slice, because a single slice. So for slice 1, basically, it doesn't care what happens to slice 3 and 2, and so on and so forth, because you only collect data for slice 1 at this point and slice 1 at this point. That's it. But from an SNR point of view, there's no improvement. It's just efficiency of scanning. You have actually more than that, but there are other issues. So it's hard to create very selective slices, that's I mentioned, in order to create. Can you hear me?
Yeah, we lost you for a bit.
Yeah, Yep, sorry about that. It's hard to create very selective slices because if you are doing this, then you need a higher time bandwidth, and high time bandwidth means that you also are going to deposit more power. Also means that your RF pulses are going to be longer, and so on and so forth. So that's going to be an issue. So really, the slice thickness is, you really don't want to go below 1 millimeter. 1 millimeter slice thickness is really, really thin for slice excitation. And so the slice resolution is often very low, and often you'll also have gaps in it because you don't want this, again, because of the issue of leakage between the slices. What you'll do is you excite slices with a certain gap. And so if you want to reformat the image afterwards, it's very difficult. Like, it's not gonna, let's say you collect data in a sagittal sagittal plane, and many slices, reformatting it will not result in a good image. You'll see either holes or low resolutions just because of this type of acquisition. Okay, but multi-slice has a huge advantage. It makes things much simpler, increases the throughput, and it's you use all the time. And you actually have a really nice way to decouple your TR from the efficiency. If you had to if you want to, for example, do 3D, which I'm going to talk about in a second, then in order to have some efficiency, you'll have to have a very short TR. Here, it doesn't really necessarily matter so much. You could just set a certain TR and then squeeze as many slices in between. A typical thing that happens is that you set a certain TR and then you said, okay, I want 20 slices, they fit in. I want to now add another slice, 21, and suddenly your scan time doubles. And the reason it doubles is because sometimes you cannot squeeze more than 20 slices. And the next the slice that you add will then have to be done after everything is done. So in that case, in order to actually reduce the scan time significantly, you just increase the TR a little bit such that that slice can be squeezed in. And so now you, again, maintain efficiency. Okay, so from a technician point of view, if you operate a scanner, you'll realize that this thing can happen. Okay, so that is a single slice, and that's great, or multiple slices. But here's a slightly different situation that I'm going to talk about, and this is called Hadamard encoding. But the idea can be extended to other type of encodings. Normally, when we excite a slice which is has a certain selectivity, right? But nobody says that the RF pulse actually just has to excite just one slice. Maybe we can excite a pattern that looks like this, and then a space, and then another slice. I mean, that's possible. Who says it isn't, right? Like, all you have to do is to play the same B1 that you would play for a single slice, but modulated with a cosine of some delta frequency corresponding to the delta Z position with respect to the gradient that you're going to apply. Okay, so the Fourier transform of this is pretty much two rext. And so you can excite that. Well, if you excite using this pulse and then do Fourier encoding, you effectively will get these will add together, right? Because you're not going to resolve the slice direction. So the image that you get is going to be, image of slice A plus image slice B. Okay, they'll just add together. Okay, well, that's great. It just means that now you have a thicker slices, basically a thicker slice. That's what basically it means, thicker slice. But what you could also do is say, you know what, I'm gonna then acquire another scan with the same similar approach, but now I'm gonna modulate with a sine. And I'm going to apply it on the J axis, so 90 degree offset. Well, then the slice profile is actually going to be, the same for slice A, but then slice B is going to have a negative phase, so it has a opposed phase. The phase is going to be shifted by 180 degrees. So now the image that you're going to get from Fourier encoding will be image A minus image B. So after you have got these two images, well, now that's pretty cool. What you could do is add these two together to get slice A and subtract these two to get slice B. And so effectively, you were able to do two scans, but by playing with the RF, you're able to basically separate it into two slices. Okay, does that make sense? And the reason it's called Hadamard encoding, because this is a Hadamard basis of length 2, but you can do a Hadamard basis of length 4, Hadamard basis of length 8, and so on and so forth. Now, some of the the downside of doing this is slice selectivity is an issue. So you really can't get thinner slices. So that's yeah, you get 2 slices kind of for, I guess, for free, or it's not really for free. This requires still double the scan time, right? That still requires double the scan time. It also increases your RF power. The bandwidth now of the RF is increased. If the bandwidth of the RF is increased, also means RF power. And there might be some crosstalk, because don't forget, this one has a ripple and this one has a ripple, and they'll ripple to each other. So, that could be also an issue. Okay. However, if you actually remember what we talked about SNR, right? SNR is proportional to the A to D time. Now, as opposed to the previous case where you excited a slice and you just observe it, just when you excited that particular slice, here we're going to collect, for this case, when we excite these two, the data that we collect with Fourier encoding has information from these 2 slices together. And then when I do the imaging of this situation, I still have, again, data coming from the 2 slices together. And that fact means that I'm doubling my A to D time. Okay, so I'm doubling the time that I'm collecting data. Doubling the time that I'm collecting data has a benefit of square root of 2 improvement in signal to noise ratio, because this is very similar to pretty much 2 averages, right? Like here, I average to, A together, and here I average, when I subtract, I average B together, right? And so I get an improvement of square root of 2 for that. So the benefit really is that, yes, it takes me twice as long to collect this, but as opposed to the slice selective part, just the 2D multi-slice, here I get a benefit in SNR. Okay. Now, Hadamard encoding, it works okay, up to about 8. If you do more than 8, then that can be challenging because of RF power. All right, so let's now, okay, so this is kind of 3D, but it's really kind of, 2D plus, right? Because you get, 2 slices, 3 slices, so on and so forth, but that's 8 slices at most, but that's it. With 3D, what you do is for example, do the following situation, is you have a volume which you want to image, and you apply a potentially, without any slice selection, although you can still do slice selection, but often will be a very large slab that you would excite. And then this thing and this thing is familiar, right? This is the phase encoding in Y. This is the phase encoding. This is the readout in X. And now we're going to add another phase encoding in Z, okay, in the slice encode. So effectively, now we're going to traverse K-space in 3D, and we're going to start in the middle of K-space, then go to the edge, and then collect one readout. And then we're going to go again from the center all the way here and collect the second readout, and then over here and collect the third readout till we finish the entire line. And then we're going to go and collect another one, another line and another line, and so on and so forth. So pretty much you can see that the scan time can be significant, right? So that can be an issue. So the nice thing about that, though, it does provide you thin and continuous slices. Because now you're Fourier encoding the slice dimension. Okay, so that adds you a significant improvement there. SNR, because you always measure the signal from the entire volume. SNR, then it will be proportional to the square root of the number of phase encode in the phase encode direction, and also the phase encode in the slice direction. So you get some advantage there, significant advantage actually, compared to just the square root of number of phase encode for 2D. Okay, so that could be, square root of, I don't know, 128. That's a lot improvement in SNR, right? That can be significant. The issue is the scan time is long, and because the scan time is long, you're more susceptible to motion, and that can mess you up. And it's very inefficient when we're talking about long TR. If your TR is long, then pretty much you're spending most of the time doing nothing. Well, in multi-slice, you could kind of interleave slices and be more efficient in scanning. In 3D, you can't do that. you excite the entire volume, and then you collect, let's say, one phase encode. Now you have to wait, and you have to wait, and that's it, right? So it's inefficient for long TR. So that's why people actually use this approach when we're using only short TRs. Okay. The other thing that could be an issue is the dynamic range. You're getting signal from the entire volume. So now your signal is very strong at DC because, it's not just one slice now giving you signal, it's the entire volume giving you signal at DC. While as you go out in K-space, your signal is significantly reduced. So effectively, you have to use more bits in order to avoid quantization error or overextending. So that often doubles the storage. So there's an option actually on the scanner. It's called extended precision, where you're actually using 64-bit floats as opposed to 32 floats. Okay, in order to be able to capture that. Let's see if Shreyas is showing up. If it shows up, say hi, Shreyas. Okay. All right. All right. So here's actually just an illustration. This is an axial. So this was a 2D multi-slice acquisition that was acquired in the axial direction. And then I try to cover the entire brain by collecting more slices in a 2D fashion. This is a 3D scan. Woohoo! We can't hear you. You're muted.
Hello.
Hey, Shreyas. How's it going?
Good.
Pretty good. Give me 1 minute. Let me just finish the 3D, and then it's yours. So this acquisition was done in 3D, so 3D Fourier, and the difference in them, you can see, of course, when you do multi-slice, then the slice thickness is usually 2 millimeters, 3 millimeters, and it may have gaps. So if I try to reformat, then it doesn't look great, and you definitely see the gaps. You see here, that can be a problem. So this is kind of not usable. So you only use them in the plane that you acquire. Well, if you collect 3D in an axial prescription, you can then reformat arbitrarily in all direction if the resolution that you've collected using the Fourier encoding is the same. So here's an example of now a sagittal, an axial, and a coronal from a single scan that you can just reformat and change because the resolution is isotropic. Okay, so there is definitely an advantage. And for 3D T1 type of imaging where the TR is very short, this is often what we do. Okay, is use this type of an approach. Perfect timing, Shreyas. Actually, perfect timing, Nikki, because I just finished exactly what I wanted to talk about. Anyway, it's really a great pleasure. Great pleasure. Like what pleasure? What pleasure? Great pleasure to introduce my friend and colleague and collaborator, Shreyas Vasnawala, I've been working with, I don't know, for how long? Like
2007?
Yeah, from 2007, we started working together. So that's 14 years now. Wow, more than bar mitzvah.
Right.
Yeah. So, I had this habit of inviting Shreyas every time when I teach this class to give this lecture, but every time it was in person, he would come here and then we would go out to Shepanis, really nice restaurant. We spend, drinking wine and good food. And I guess not today, unfortunately, but at some point, Shreyas.
Yep, we'll figure something out.
We'll figure something out. Just as an anecdote, I have to say, when Shreyas did his PhD, is an MD PhD, but he did his PhD, the same group that I did my PhD. And when I started, they assigned me a desk, and that turns out to be Shreyas's desk. And Shreyas left a lot of stuff there, and I kind of moved them away. And he got really upset that somebody, moved his stuff. And then everybody told him, it's just like, well, wait, what do you want him to do? I mean, just wait for you to move your stuff. Anyway, that didn't hurt our relationship in the, later in the future. So we're still good friends. So thanks, Rest, for warming the seat for me and for all these years. And yeah, and now I'll just let you do your thing, your magic.
All right. Okay. Yeah. No. Thanks much. This is always a lot of fun. It's good to see you, Mickey, and many folks on this group that I've had a chance to meet before, and some new folks. So it's wonderful to connect. In the past, I've shown only MR images and cases that are just MR. This time, it's going to be MR heavy, but I'll try to show some of the MR in the context of some other imaging as well. So it may help to give you a sense of how MR is used. So I'm trying to share. Okay, there we go. Perfect. All right. So we'll go through some cases here, and I think this is something that Mickey said has gone over reasonably well. It's produced a decent amount of interest. Gives you a sense of how MR is used in our clinical practice. I'm a pediatric radiologist, so I work out at Lucile Packard Children's Hospital. And so the cases that I'm going to show you here are largely on kids. So,
hey, Shress, is it okay for people to interrupt?
Oh, absolutely. Yeah, absolutely.
Yeah. So feel free. It's really easy to interrupt Shress. I do that all the time, and he takes it pretty lightly. So don't be afraid.
Yeah, no, that would be great. So
Shress, hold on, just a sec. You see, I interrupted again. He's smiling. Not a problem.
So great. And yeah, I have a ton of cases here, and we only need to make it through a few of them. So it's up to you how far we want to get with this. So here's the first case. So this was a 3-year-old who presented with pain in the pelvis and came to the emergency room. And so the story here is that there was an ultrasound that was done to look for appendicitis, and that was negative. And then there was a pelvic ultrasound, and there's an ovarian cyst seen. And then they finally got an MR. And so I'll show you these. So this is the ultrasound. And what you're looking at here is that the transducer is placed on the belly. And then you can see here, there's an ovary, which is this sort of small structure here. And I think there's a portion of it that looks a little different back here, but wasn't necessarily recognized as such. And it's a Doppler exam. So you can see the color Doppler, and there's a not obvious flow there, but then on a pulse wave Doppler, you see some arterial flow. And back behind here, I'm not entirely sure. I think this is a fluid-filled rectum. So here's the MR images that we got afterwards. So there's 2 types of images. So this is a T2 weighted image, fast spin echo, axial, and the fat is bright. So there's no fat suppression. And what you're seeing here is a large ovary, right? So if you see this, so this is way too large for a 3-year-old. And there's a large cyst in the middle of it. And one of the things that you'll notice is that there's all these little follicles, right? So normally, once you've sort of reached puberty and beyond, you see these follicles, and monthly you'll have one of them that matures and then eventually ruptures to release an egg. But in this case, we're seeing these that are too prominent for a 3-year-old. And the other thing is that the tissue that is in between these follicles, so these regions here, is just too bright on these images. Okay, so this is reflecting edema. There's too much fluid here. So that's the T2 weighted image. And then this is a T1 weighted image that's done post-contrast. And in this T1 weighted image here that's post-contrast, you can see again that ovary that's in the middle. And notice here how these blood vessels are all bright from the contrast that's come on board, but this ovary is quite dark, right? So wonder if anybody sort of would want to hazard a guess as to like what's going on with this child that has pelvic pain, and they've got this huge ovary that's kind of swollen and not really enhancing here. And sorry, I couldn't hear. And it's
Somebody
okay.
said something.
Yeah.
Somebody said something. That's okay. Yeah, please say it.
Totally wrong. It doesn't matter. You're not expected to know.
Oh yeah, can you hear me?
Yeah.
Is this like not water, like the fluid? Like some, maybe some like more sticky or I don't know.
Yeah. Yeah, so there's definitely more fluid there, right? So you see like this follicle's gotten way too big. And not only that, but there's fluid all around the ovary. Like, do you see all this fluid right here, these bright areas? So this is what's called ovarian torsion, right? So the ovaries, they come off of each side of the uterus, and there's a ligament that's called a round ligament that winds up connecting them, or sorry, the broad ligament that connects them to the uterus. So if that twists, then it cuts off the blood supply and the ovary gets swollen, right? And eventually, if there's no blood flowing in, it will actually die, right? So if you can diagnose this in time, then you can actually go in operatively and detwist it. This case, though, I don't think is going to be salvageable. So you see the ovarian edema, that suggests you know that there's torsion, but this post-contrast exam that shows no enhancement really says this is probably not a viable ovary.
So no blood supply, I guess, right?
Yeah, no blood supply. It's sort of twisted off here. So let's see. I think this is, yeah, just a little video clip here. And so you can again see. So these are what are called single shot T2s. So you can see there's no real motion artifact from this because each scan is just acquired within, each slice is acquired within a second. And so you can see here again, this very edematous ovary surrounded by fluid.
You could also see the blurring, right? Except for long T2 species where it's pretty sharp, but whatever is short.
Mm-hmm. Yep, like the edges to the bone are blurred.
Because the signal decays while you're collecting the data. But for the long T2 ones, the water is pretty sharp because it doesn't decay much.
Mm-hmm. So here's just a look. This is the same patient, but it's let's see here if I can show it. Yep. So this is again just coronal single shots, but this time there's fat suppression, right? And so you see again this central ovary there that's edematous, and for the most part the fat suppression works at least where we want it to. But notice here you can see there's failure fat suppression out here. So another little region of failure fat suppression doesn't really bother us in this case. The single shots are working quite well to show us this. So here they went in operatively and it was twisted 720 degrees. So 2 twists of that ovary. So, yep. And so this is kind of a nice example of how MR complements the ultrasound. So the ultrasound showed Doppler flow, but what it was really picking up, if you go back, is that there was a little bit of arterial pulsation in there, and that stayed present, but the venous flow was cut off, right? So there was no egress of blood. So essentially no perfusion to that ovary.
Shreyas, are we able to see the twist from MRI?
You can see it on post-contrast images sometimes. The clue is really more that the ovary is sort of sitting in the center. You know, usually it's off to one side. So when it gets twisted and you see it sort of move to the middle, that's a sign that it's twisted. But usually it's not so easy to see the twist itself directly.
Okay, thanks.
Yeah.
Could you explain what the bottom ultrasound plot was showing?
Oh, yeah. So we'll go back to this. So here there's a little gated area here. And in this area, this is looking at the Doppler shift of the ultrasound signal over time. So this horizontal axis is time. And then that Doppler shift is converted to a velocity. And so you're seeing the velocity of blood flow there. And it assumes that the direction of flow is in the direction of the ultrasound beam. So there's a lot of assumptions built into this. So I don't think that these numbers are actually accurate, but the waveform tells you it's arterial flow.
Great, thank you.
Yeah.
Is the ovary typically this big, or is it because of the edema that it's this big?
Yeah, it's because of the edema. It is not normally this big, and especially in a 3-year-old, it's not normally this big. So usually what happens right at birth, it's very obvious because of maternal hormones, and then over a period of a month or two, it gets much smaller, and then right around puberty again, it increases in size.
Is it known like how the torsion occurs?
You know, many times there's some mass on the ovary, right? There's some lesion there that predisposes to a twist. I think in this case there wasn't anything. It just happened. The analog that happens in males is testicular torsion. So same thing can happen. And there, the testicles, they start in the abdomen, they migrate down to the scrotum. And there's a point that usually there's fixation that happens. But sometimes that just doesn't happen. So then it can just freely sort of twist. And so in males, I think it's understood more from that perspective. From females, it's more often that there's a mass on an ovary.
Yeah, I've never even heard of that.
Did this happen like from birth, or was it something that happened like later, or yeah?
Yeah, later. Yeah. So this presents like, almost on a dime usually, like you're feeling fine and then, you feel quite nauseated and pelvic pain. So, okay, so that was the first case. Any more questions on that one? Okay, so this is an 11-year-old male, lower abdominal pain. So here's the ultrasound. And I show this in part to give you a sense of why we love MR so much. So here you can see it's pretty hard to actually get too much out of this. So get the sense that, okay, there may be some lymph nodes there. So like this region here, maybe it's a lymph node, hard to tell. Here's the MR. And so what's wonderful about this is that it's so clear. You can actually see what's going on. So in this case, there's a uterus here. No, sorry, that's not a uterus, that's a bladder, the top of the bladder. And one of the things that you're seeing here is that this little loop here is the appendix, and it's gotten pretty dilated here. So does everybody see that? So this right here is appendix, and it's got some debris in it. And so this is a nice case of appendicitis, again on single shots. And each of these single shots take about half a second to acquire.
So do you typically do MR for appendicitis? Isn't it like an acute case where like rushed into?
No,
procedure?
so first step is ultrasound. So if ultrasound can establish the diagnosis, then done. If it can't and there's still a suspicion, then we get an MR. We used to do CT, but we've stopped that for the most part because of the radiation concerns, and do MR. And in MR, it's really these single shots that go a long ways. So here's the coronal single shot with fat suppression. You'll notice here, this one is not as clean as the prior image, the prior example. So maybe you'll notice all of this artifacts that are all over the place here. So I wonder if somebody sort of has a sense of like, what is this artifact from? So what is going on over here? So
I have
just
two hypotheses. I have two hypotheses for that.
Yeah. And just while you're thinking, just to give you a little bit of normal anatomy. So here's the spine. So you see all the little vertebral bodies, and on each side of it, there's a kidney and a kidney, right? And here you can see the hips. So this is like the head of the femurs on each side, and the urinary bladder. So, yeah. So what is sort of...
So somebody said something, but can you just repeat what you said?
Are those arms?
They are. Yep. So they're arms, and they don't quite look like what you would expect arms to look like, right?
Right.
So part of this is that they're distorted from being so far out from isocenter of the magnet, right?
Mm.
And so there's a correction algorithm that are on the scanners to deal with the gradient nonlinearity that far out. So for instance, you almost see it here. Like, do you see how the edge of the image is curved here, right? Like, we don't actually have a rectangular image. And that's from this correction algorithm, but it only works so well, so here you can see that it's not fully corrected things. Second is when you get far out from isocenter, you don't have the same field homogeneity that's in the center of the magnet. And so you have these areas of fat suppression failure. So for instance, here you can see like the bones in the hand, which have been heavily distorted, and the bone marrow, which normally contains a lot of fat, is not suppressed here. So for instance, here you see the bone and marrow in this vertebral body. It's nice and dark. And here you see it bright. So
Cool.
yeah. Yep. And I'm not fully sure exactly what is the full source of this artifact though here. I think there's probably something more going on.
It looks like fat suppression that failed somehow, I guess. Maybe also with aliasing.
Yeah, maybe the combined, has produced this. So yeah. So here again, so you can see very nicely, that's the appendix there. And part of sort of the training of a radiologist is that there's all these loops of bowel, but how do you recognize appendix for appendix? And so,
Was that anesthetized too?
No, we don't do
What-
anesthesia for any of our appendicitis MRs.
Is this a tube though on the right? This, like, you can actually see on the right side of the image.
A tube on the right. Oh, this thing?
Yeah.
Yeah, so that is a tube for IV contrast,
Okay.
right?
Cool.
So yeah, so IV contrast. Mhm. So here's the post-contrast images of the same patient. And so you'll see here, that's the appendix, and it's really dilated right there. And so it's just a nice example of appendicitis. And this particular sequence, I think, is kind of interesting. So you'll notice you actually see all these structures outside of the body here. So I wonder if anybody's got any guess as to what are we seeing there?
Is that 3 cone stress?
That is. So a hint to this is that this is a very short echo time scan. So it's probably around like 8 microseconds echo time.
Yeah. So what's on the bottom, folks?
Is it the table?
Yeah, table or even the coils, the receiver coils. Yeah, table and receiver coils. And so we're imaging solids here, right? Because the echo time is so short that you can image that. The other thing you'll notice are these little arcs. And so I don't know if you can see that over Zoom, but there's all these little artifacts that are arcs here. And this is sort of typical of this sequence that doesn't have a Cartesian sampling.
Yeah. So this sequence is it scans cones in 3D case space. So it's a pretty cool sequence. Instead of doing spirals that we talked in 2D, in 3D you could actually do a cone, and so it covers the entire 3D case space. And because you start immediately reading out after excitation, then the echo time can be very, very short, on the order of just a few microseconds.
Yeah, we really like it for this protocol because this acquisition takes a couple of minutes and somebody's breathing away, but you don't even notice any respiratory motion in this at all. And also you don't even really notice much in the way of bowel motion either. Usually the bowels are peristalsing and moving along, but here you don't see anything like that. So, did you talk about the point spread function for spiral scans at all?
We did, yeah.
Yeah. So if you look here to this arm that's way off isocenter, we mentioned that the field homogeneity is not as good out away from the center of the magnet. Notice the blurring of this arm, right? It looks nothing like the sharpness of the image in the center. And so this is just a nice example of what happens when you're not on resonance with this type of acquisition. It leads to a blurring. So,
So it's like Cohn's trajectory, like clinical protocols now.
oh yeah, we've been using it for years, day in, day out for this type of post-contrast imaging. I'll show you some other examples too.
Oh, awesome. Thanks.
But it's not a typical thing that people do in general. is
No,
it?
yeah, it's just in our practice. Yep, just in our practice. Mhm.
Another question is, what is the final like diagnosis of this patient and how?
Yeah, so this is appendicitis. So ruptured acute appendicitis. Yep. So
So did you have to do an MR instead of just because the ultrasound wasn't definitive, or?
yep. So the ultrasound, we couldn't find the appendix. So this is what we were looking at. We saw some lymph nodes in there, but just couldn't see the appendix. And one of the problems with ultrasound is that when there's bowel gas, you can't really see through that so well. And so it's often hard to know exactly what you're dealing with ultrasound. So we try with ultrasound first. If it's not definitive, then we'll move on to MR. Yeah. So here's another case. So this is a 8-year-old female. This time pain is in the right lower quadrant of the abdomen. And so here you have again an ultrasound, and this is a loop of bowel, and it's filled with fluid here. And that's all we have off of this. And here's the equivalent MR. And so again, you'll notice here, there's a loop of bowel right here, and this loop. Both of these are abnormal. And one of the interesting things about this is normally the bowel, you should not see this brightness within the wall, right? So there's significant thickening of the wall and edema within the wall of this loop of bowel. And you shouldn't see all this fluid all around the bowel. So this is another example of a lot of inflammatory changes there. So kind of a good reason for somebody to have pain. And so, yeah, so you can get a good sense here. And actually, I do ask our technologists to have somebody urinate before getting on this table. So, but here you can see they probably didn't. So the urinary bladder is quite full. So sometimes that puts a constraint on how long we can scan these patients. So
this is a T2.
This is a single shot T2. Yeah. And you know, one of the things that's sort of interesting here is that if you notice, we tried to fat sat this, but if you look at the back, you notice that the fat sat is not perfect, right? It's not totally dark. So this is all fatty tissue here. This is muscle, right? So this is buttock muscle here. And so, you know, I wonder if folks have a thought as to like, why is there such a thick, dark line between these two?
I guess there's the same amount of fat in the muscle on the boundary.
Okay. Yeah, I'm not sure I understood your logic. Maybe you could flesh it out a little bit.
Sorry, I missed something. I thought it's about in-phase and out-phase things.
Yeah, so if you have a gradient echo image, then you can get effects where you have at the boundary of fat and water, these dark lines due to signal cancellation where there's fat and water in the same voxel. Okay. This is a spin echo image, so I'm not sure that the logic that you applied it is correct in this case. Yeah, it's a good thought, but I think there's more to the story on this one.
What was the bandwidth that you collected?
Yeah, so typically we do these at around 40 kilohertz.
40 kilohertz. So that's a relatively low bandwidth.
Chemical shift.
Yeah. Yeah, so absolutely. Yep. So there's really just a shift in the fat relative to the water in these images, right? And so it's just manifesting here, and you see it pretty clearly. So, and in fact, I think, I'm not 100% sure, but I think on these images, the readout direction here is right left. The phase encoding is AP, right? And so you notice that here in the readout direction, you don't see it so much on one side. You see it more on this side. But then in the phase encoding direction, it's even more prominent, right? So
That doesn't make sense.
yeah, so I wonder what exactly here, but this I think is a chemical shift issue.
I don't know, Shiraz.
Yeah.
You shouldn't see any shift in the phasing code.
Well, you do see it like with EPI sequences, right? Between fat.
EPI, but this is a spin. But this is
Yeah,
a fast
this is
spin.
spin echo. Yeah. So then, what's accounting for this?
I mean, you actually see also a line at the top, so like up here too.
Right here.
So I don't know.
Yeah.
Maybe
So maybe this is true chemical shift here, but what's going on, on this side? Because it's asymmetric right left.
right.
Bit of a mystery here. So here's again the cone sequence here on this case. And so you can see again that inflamed area. And this is the appendix right here. So again, this was another case of just ruptured appendicitis.
Mm.
Okay, so I'm going to switch topics a little bit, talk about musculoskeletal imaging here. So this is a 12-year-old, numbness and tingling, okay, sensation with a fifth and lateral aspect of fourth fingers after a fracture. So here's a look at, this is the forearm. So we're kind of cutting the forearm like this, right? And so you can see the two bones in the forearm here. And you can see that this is fast spin echo in this case. And you'll notice this is from the fracture. So you see some edema in that bone, a little bit of edema around the bone. But the thing that's really interesting in this case clinically is that normally you have sets of nerves that go down the arm. So and they follow the vessel. So for instance, there's a vessel here and there's small nerves on each side. But take a look at the vessel here and then look at these bright nerves. You see all the little fascicles here. So you can see that in this case, there's a neuritis. That nerve got irritated by the fracture, probably got traumatized. Now the nerve is enlarged and edematous. And that accounts for the tingling that's very prototypical in its location on the fourth and fifth digits. That's from your ulnar nerve. So usually you have a radial nerve and a median nerve and an ulnar nerve, 3 nerves that go into the hand. And in this case, the ulnar nerve got damaged. So, and I'm not, super happy with the scan. You can see that it's pretty low SNR, right? So you can see quite a bit of noise in the images. And then of course you see this artifact. So I wonder if anybody's got an idea what this artifact is from.
Is that motion blur?
Yeah, what kind of motion?
I have no idea.
So what's inside? What's inside? What is this thing? That's the question.
Is it
Artery.
Is it what?
blood flow?
Yeah, it's a blood vessel. Yep, it's a blood vessel. And what's kind of a little bit interesting about this is that this is not an artery. Like you would think it'd be an artery based upon, this pulsation artifact. It's a vein, right? So I think this vein had some pulsatile flow in it as well. And I know it's a vein because there's just not a normal artery out in that location. So, yeah. So that's a nice.
And you could see also the how do you call this, Yeah. I think you could see the, how do you call these in the veins? The open up and close.
Oh, valves.
Yeah, I think you can see
Uh,
maybe,
Yeah, I
or
don't know.
maybe
Yeah,
it's
I
a
don't know.
flow.
Yeah, and it's kind of interesting. I don't fully understand this image either, because ordinarily when you do spin echo images and you have fast flow, like here's an artery right in the
Mhm.
center here, you will have black blood there because you do a 90 excitation and then you wait a little while and do refocusing pulses. And in that time between the 90 and the refocusing pulses, the blood leaves that slice, but never gets refocused, right? And so that's why you see this sort of black blood there. So here, this must be slow enough flow, for
But
most
still
of
pulsatile.
what's that?
But still pulsatile.
But still pulsatile. Yeah, exactly. So it's kind of slow flow that's pulsatile here that produces this look. The other thing that you'll notice, like watch these vessels here, you'll see that they're dark, 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 and then they become bright here. So some of this is just in plane or slower flow as you get to the end of the vessel. The other thing is for veins, you'll see here also that the slow flows on the edge, of the vessel.
Mm.
So anyway, yeah. And then also you'll notice here, this is not like single shots where you get an image and you get the whole of K-space, then move on to the next one. Here you get some phase encodes and then move on and get others. And this is done in a couple of banks. So that's why the arm seems to be bouncing right through these banks. There was patient motion in between banks of images that were acquired. So
Experience, you show like some arteries and some nerve, not some veins and some nerves, but they all shows like in a bright way. So how can we tell the difference between the nerves and the?
Yeah, that's a good question. Sometimes we struggle with that, but oftentimes you just know. So for instance here, like the center is the artery, that one. On each side, there's a vein. So usually the veins in the arm and the legs actually at this level will go in pairs around the arteries. And then this looks nothing like a vessel. That just has the look of a nerve. And in fact, it has all the little fascicles of a nerve. So on this sequence, I tell by the look. There are other pulse sequences where you motion sensitize it even more. Like, for example, there's a DES sequence that can do that, where there's a little bit of diffusion sensitivity. And then the arteries and the veins, they have no signal, and all that's left is the nerve. But that's not the case here. Here it's just from pure anatomy. So let's see. Let me go into this. So here again, this is the ulnar nerve, and you just know it's edematous, right? So that's how you know it's abnormal. So, we have like some lookup tables that we use to see, okay, well, what's this, normal sizes of nerves and the signal intensity. I think it's hard to really use this particularly well. It's usually more of a gestalt, right, of what's normal and abnormal. So, yeah. So that was a nice example of a forearm with after a fracture and there was a nerve injury. This is a 10-year-old female with knee pain. And so you'll see in this case, this is, I think, a sequence that Mickey knows particularly well. So this is some of the work that was done out of Berkeley on T2 shuffling. And so that's the example that we're seeing here. So in this case, I'm sorry, it's pretty zoomed up, but this is like your kneecap right here. And so this is the front of the knee. The back of the knee here is on the right side of the image. And then you're seeing cartilage that surrounds the bone. This is fat suppressed. So you see the fat is all dark in the bone. This is a kid. So kids have these growth plates in their bones. So there's cartilage within the bone and new bone forms from this cartilage. So that's how somebody grows taller. And one of the main findings here is that there's just too much fluid. So if you look here, there's all this fluid, and this is abnormal. So usually you don't have that much fluid in a joint like this. So it's what's called a joint effusion. So, and just as a nice example, this is an ACL, anterior cruciate ligament. So folks have probably heard of this from like ski injuries, right? That's the anterior cruciate. This is the posterior cruciate ligament here.
And they're dark on MR because of the T2.
exactly. Yeah. So
T2 is very short for them.
yeah, and then this is a meniscus. So you'll see. So you may have heard of like people who have meniscal tears. So that's the meniscus that's there. So let's see. So in this case, yeah, it looks like quite a bit of joint effusion. And the other thing that you'll notice here is that there's the lining of the joint is too thick. So if you look at this, you shouldn't be able to see this thickness in the lining. So that lining is just too thick, which tells you there's inflammation of that joint. Okay, or the synovium is thickened. Okay, so this is a case of like idiopathic arthritis, or you may have heard of like rheumatoid arthritis in adults. This is the pediatric analog of that is what's called JIA, juvenile idiopathic arthritis. It's similar to rheumatoid arthritis, and that's what we're seeing here. Okay. So questions on that one before I go on to the next?
What will be the treatment?
This one, yes, it's anti-inflammatories. So usually they're biologic agents these days. You know, more historically, it used to be more steroids, but something that just tamps down on the immune system.
I see.
Yeah, and sometimes you can deliver those just by sticking a needle straight into the joint, and then you just inject right into the joint, say steroids. Yeah, and then it'll calm things down. So yeah, this case, I'm not sure how interesting it is. This one is just a nice example again of a T2 shuffle that was done on an ankle where somebody twisted their ankle. And so you can see this is the ligament that connects your tibia to the talus. And that looks normal, but then you see all the soft tissue swelling here and a little bit of swelling in the bone marrow too. So yeah. Let me just go past this one. I think this one is sort of harder to appreciate the issue, but maybe I'll just go through it a little bit here. So again, this is that T2 shuffle sequence. And so this is the fibula bone. And I think Mickey is quite familiar with this anatomy these days. So, yep. So kids, again, they have these growth plates, and you can see the cartilage is quite bright here. And in this particular case, the bone, if you've noticed, or the growth plate is lost right here. And there's a bone bar there, or bony bridge, right? So these are quite problematic because if the younger you are, you need this growth plate in order to grow. So if you have a bridge right there, growth will continue on this side, but it will be impeded here. And so this bone will now start growing outward, right? And so you wind up getting a deformity of your bone, right? So it'll actually start curving unless this is treated. So often what happens is surgically, this bar is actually excised. So sort of just a nice example of a bar there, bony bar.
Oh, just a couple, just one thing. So T2 shuffle, just for those who are not familiar, is just a sequence that allows you to get in a single sequence different T2 weightings, from proton density to slight T2 weighting and a lot of T2 weighting using computational methods. So that John Tamir developed when he was a PhD student here. Now he's a professor at UT Austin.
Yeah, the thing I love about it is that it removes the blurring from the T2 decay. So the images, just that they have such sharp delineation of anatomy, and especially things that have short T2. So, you know, you just really see them clearly. So for example, like here, you can see these are tendons that are coming down, these really dark areas here, or these are tendons here as well. This is a ligament here. They're very short T2, but they're still seen pretty sharply here.
Hey, Shreyas, I have a question about T2 shuffling in clinical settings. So it has a lot of different contrasts. So how do you leverage different contrasts to make diagnosis?
Yeah, so I usually look at the way that it's set up. It reconstructs at 3 different effective echo times. I usually just look at the middle one, you know, and then if I want to see some subtle edema, I'll look at like the long echo time image. And then also if I think there may be a cartilage injury, it tends to show up well on the short echo time images. But for the most part, I'm looking at the intermediate one and making most of my analysis on that. what would be ideal is, that you could just have one look, and then as you're looking at it, you can dial the that effective echo time to what you want.
Yeah. Thank you.
Yeah. So this was a kid with what's called an arteriovenous malformation that was in their calf. So 15-year-old. So just a nice example. So here you see the femur bone. This is heading down towards the toes, right? This is up towards the head. This is the front of the body, the back of the body. So here we have spin echo T1, right? And then this is fat suppressed post-contrast imaging. And similarly here too. And you see this huge tangle of vessels here. Most of them are bright. A few of them show up as flow voids here, right? Which means there's fast flow in some of these, and the rest have been enhanced quite a bit. So this whole tangle of vessels is what's called an arteriovenous malformation, and it's in the calf muscle in this patient. So here's just a look at the axials, and you get a really good look at this here. And one of the things that's interesting is that you may have heard, sorry about that. You may have heard of gastrocnemius muscles. I don't know if you, gastrocs, that's your calf muscle. So this one, this medial one, you'll notice that there's a lot of fat replacement in it, right? So notice here, this is how the fat is totally suppressed here. And actually suppressed is the wrong word, it's separated in this case. So this is a 2-point Dixon acquisition. And then this is the water image that's generated from that.
That's when you acquire an in phase and out of phase and combine them such that you can separate the fat image and the water image.
And so the nice thing about it is that compared to like the other examples of fat suppression that I've showed you, notice here how throughout this image, like all of the subcutaneous fat is perfectly dark. Like there's just perfect fat suppression. So if you really want that, then you need to use a technique like this, but at the expense of scan time because you have to get the 2 echoes. And so here you have also this fatty replacement of this muscle. So this is a pretty prototypical example of what's called a fibroadipose vascular anomaly, which is a subset of AVMs. So,
is this a life endangering thing or?
No, I don't think so. I mean, and these are amenable to treatment, but it's not life endangering, but it is life limiting. So that these ones can be pretty painful, and then other types of vascular malformations, they could cause things like a limb will just grow too long because there's just too much blood flow there. So one leg will be much longer, the other it'll overgrow, or just increase in girth. Or you can have like a skin ulceration, and oozing and bleeding and, those types of things. The other thing that can go really wrong with these is sometimes they work their way into a joint and then it'll bleed into the joint and then destroy the cartilage in the joint. And so you can, have mobility problems from that. So
it's not the same as AVM in the brain, for example, where it's like
yeah, that's one where that's life-threatening. Yeah. And I think later on I have a case of a vascular anomaly. It's not quite an AVM, but a vascular anomaly in the brain. So you'll see what that looks like. So let's see. So this one,
how is a rare? Is that disease like very rare?
No, well, vascular anomalies I think are not that rare. Ones that need treatment are much more common. So the most common vascular anomaly is what's called a hemangioma. I think like the percent of people walking around with the hemangioma somewhere in their body is like 5% of the population or 10% of the population. So these things are pretty common, but ones that actually require you to do something about it are less common.
yeah, I mean, we had a few incidental findings from the 10 subjects that we scanned. That had some blood vessel malformation.
Yeah. So let's see. So this one, I think, let's see here if I want to show this case. I'm not 100% sure I want to show this one. Yeah, let me just see here if I can. This one I think is a little bit too complicated to talk through. Let's go on to this one here. So this was somebody presented with a chest wall mass. And so here you can see on ultrasound again, you see this lesion here. It's not producing a lot of echoes. It's not got a lot of flow in it, right? You can see the scale here. Supposedly, 5 centimeters per second is the scale. So it's set quite low for high flow sensitivity, and we don't see flow within it. This is a look on kind of the gray scale. And so again, you see this lesion here, but it's pretty hard to characterize what it is exactly. Anybody know what type of imaging this is?
Yeah.
Right, so just standard projection radiography, right? Very old school. So, but here you can also see that it's not exactly clear where anything is, although that diaphragm is elevated. This lung is edematous here. There's a pleural effusion. So now here's the MR. So in this one, I think it's sort of a nice example. So it's axial T2. And there's
Trusting you, hold on for a second. Let me just show the artifacts here.
Oh yeah. Let's how about, let me go to this one. How about that?
Yeah, that's a good one. Anybody has an idea what these artifacts are from?
Respiratory motion.
Yep.
Yeah, I think so. So
I think so too, yeah.
yeah, in this case, which direction is the phase encoding direction? Is it right, left, or is it kind of top, bottom?
So we haven't reached talking too much about artifacts, but usually you get artifacts when you have inconsistent measurements. And that often is done in the phasing code because that's a slow dimension. So if you have inconsistency there, you'd see kind of spreading of the signal and aliasing and all sorts of ghosting actually that looks like that.
Yeah.
So you can see them in one dimension. The other thing is that another indicator is phasing code. Usually want to apply it in the thinnest dimension, and readout, which is not limiting your field of view, is the longer dimension.
Yep. Yeah. So the readout is right, left, because you can see how much coverage you need here versus anteroposterior for phase encoding, and that's the direction you see the ghosting from the wall of the chest, right? And so the anomaly here is quite striking. And so with ultrasound, we just had no idea that there was actually this problem, but this entire thing is a mass. It's a tumor all through here. So
this huge thing
is a tumor. Yeah.
Oh wow.
Yep. And then there's all this abnormal fluid around the lung. So this very bright is just pure fluid. And of course, the dark is the air of the lungs, right, which doesn't have much proton density. And then these dark areas are vessels that have fast flow through it. And it's a spin echo sequence. That's why you don't see bright signal. And so you can see that there's a massive mass there. And on top of that, notice what's happened to that fluid around the lung. So here you see the fluid, but you also see there's a rind of mass there as well. Okay, so that rind of intermediate signal is also a tumor. Wow. So here's, this is single shots showing the same thing, but coronal plane. So now you see a lot.
How old? How old is the patient?
Let's see. So this one was 11 years old.
So it took a while for them to notice it.
I think so. Yeah. I mean, to get this big, and like you could even see here, like this is a vertebral body, this is a spinal cord, and there's actually mass that's sort of working its way, almost into the spinal canal. And then also you can see like here, there's mass pushing on the liver, right?
Wow.
So yeah, so this is pretty extensive disease there. Let's see, there was sort of one other thing to show. Yep. So one other thing, if you notice here, this is the airway, right? So this is the trachea. And so watch as I go down, watch what happens to this trachea. So you see how it's
Oh.
now squashed. So the mass is there. Hold on just a second. Sorry, I got a just slight issue here. Canceled. Okay, all right, thanks. So yeah, here's this airway that's been squashed and it can't move, right? There's a mass here, there's a vertebral body here, and so it's completely squashed. We've had cases where it's unsuspected that there's a mass like this. A kid undergoes MR, they're getting ready to put him under MR and they anesthetize him. And when you anesthetize, you give a paralytic that takes away muscle tone. And when the muscle tone of the chest is gone, this airway will just completely collapse. And then the child will arrest. And, you know, it's just unsuspected because you didn't know that there was a big mass. So, yeah. So in this case, I think there was enough suspected that didn't happen. Let's see. So, yep, so I was showing these, I think. Let me just see.
Okay, Shreyas. So from the images, it seems like the tumor part is pretty, like the contrast is pretty uniform. How can we tell like more information about this tumor?
Biopsy. So usually biopsy. So like our role here, I mean, a couple of things. One is we sort of know up front that if you have like, you know, a kid in this age group with a mass in this location, there's like four things that it can be, right? So we all often offer a differential diagnosis, right, of that. One of them is lymphoma. Other ones that tend to happen are what are called teratomas, which have fat in them, right? So you can tell, okay, this one has no fat in it, right? So off of those two most common ones, we've excluded one. This is most likely lymphoma. But ultimately, though, you know, these things still need tissue, right? So these need a tissue diagnosis, and so they would go on to biopsy. Yeah. So this one was again a lymphoma in this case. Okay. So let's see. So this is somebody who's got thyroid cancer, 11-year-old, and now has an ovarian lesion on ultrasound. And so you can see again this ovary here. So this is the water image. This is a pure fat image, which is helpful because you don't really see any fat here. Here's a post-contrast images, and this doesn't really enhance too much.
What is not enhancing?
The lesion, the ovarian lesion. It's got a little bit of enhancement, but not a lot. Here you see it, and now it's on the delayed phase, more intensely enhancing. So here's uterus, here's rectum. This is iliac bone. This is front of the body, back of the body. So, and so this one happened to be also a malignant ovarian tumor here. So in this case, so this patient, they have a mutation that predisposes them to cancers. So that's why they had like thyroid plus this. And a decent amount of work is actually around looking at these types of patients and giving surveillance exams, like say every 6 months or so, to try to catch these types of tumors early. So let's see. I'm gonna go maybe a little bit quicker. How much more time do we have, Nikki? Maybe 2 minutes, or what's the?
Yeah, usually we finish at 5. Sometimes we go a little bit over, so it's up to you. I mean, I'm sure people would be happy to stay if you have time, but we'll be respectful of your time.
Okay, all right, maybe we'll look at this as the last case here.
Okay.
So these are coronal single shots. I have no idea why they're so grainy, but they're quite grainy here. They're fat suppressed, but notice here up at the clavicles, the fat suppression has failed. And this is a very typical place for fat suppression to fail. And it's because right where you have these air tissue interfaces, like right where your shoulders are and the lungs are below it and up at the neck, it's very hard for the field to be made homogeneous there, right? So when you go into the scanner, these susceptibility effects cause significant field variation. And so we really struggle with good fat suppression here. But on these single shots, you can get a good sense of the cardiac pulsation. This is probably an image that was obtained when the heart was at rest in diastole. So you see some of the muscle there. These ones are probably acquired in systole. So where there's just enough motion that all of the signal is blown out. But the interesting findings here is actually this structure here.
Oh, wow.
Yeah, so this structure, if you follow it up, it's a squiggly tube, right? That's coming all the way up here, gets really dilated, and ends right here. So this is, I think if anybody can name even the organ system of this problem, I think Mickey will take them to Chez Panisse.
Thanks, Shreyas. I really appreciate it. Huh. Can you show it again? It
Yeah.
goes from up here.
Well, you can see it's actually going from below the diaphragm, right?
Wow.
You see that? And then working its way up here.
Is this the lymphatic system?
It is. It is. It's the lymphatics. Yes, you should take yourself to Chez Panisse.
Yes.
No, wait, that's what I was gonna say.
I know, but that's why I said it quickly, because I knew you were gonna say it.
I was just about to say that.
Yeah. So there's this is part of the lymphatic system. It's an organ system that people sometimes forget about, right? But this takes excess fluid in your body and brings it back into the venous system. And so from the legs, there's all these channels that come up and they form a structure that's called the thoracic duct. And this thoracic duct will go up and it drops into the left subclavian vein here. But in this case, that there's an occlusion of this duct there. So all the lymphatic tissue is just building up there. And so this is sometimes also called like a central conducting lymphatic anomaly. And it's treatable too, so you can actually go in through the vein with the catheter and then just balloon up that area once you access it and try to bring some relief. So it's kind of a nice example of just looking at single shots, and the fluid is so bright because it's just pure, it's pure lymph. It's pure simple lymph fluid there. So
you use a lot of single shots in your practice, I see.
a lot, yeah. So here's like
That's because pediatrics is it because or you'd use that also in adults?
No, it's really a lot in pediatrics. Yeah. So here's like an example just showing where, these in green, these are these lymphatic channels. And so this is a subclavian vein here coming off and then comes back to the heart through the brachiocephalic vein. And normally these, this duct drops right into there. So, yeah. So maybe I'll end with that case.
Yeah, thank you, Shreyas. That was amazing.
Yeah.
Really appreciate your time and coming to and then give this presentation. I really appreciate that. Maybe 1 or 2 questions, then we'll finish. Is that okay?
Yep.
Oh, actually, I have a question about like the clinical practice. Like when a patient comes, it first refer to ultrasound usually, or like to X-ray, or like when does the MRI just come in, step in?
Yeah, it's very few cases where an MR is the first line modality. I think you could argue that if it was more available, it should be the first line modality in a lot of circumstances. And I've definitely seen, I would say maybe even like every other week or so, a significant misadventure, like due to an ultrasound or, where if just somebody had gotten an MR, you would have been spared like a lot of problems, right? But it's really the issue is really around access, cost and access. But otherwise, it's pretty good. Cases where you go straight to MR, maybe headache. I can't think of a lot where you go straight to MR. It's usually X-ray, ultrasound, echo.
Or if you just request it. And
or if you just request it, yeah. If you demand it, it's like, I want an MR, I don't want something else.
No.
Is the limiting factor like just is it like the time for an MR scan versus another scan, or is it more so of like the availability of machines, or like what is? Or
Yeah,
like
well, I guess those are related, right? So yeah, so part of it is that it is a, it takes roughly an hour for a lot of exams, right? A typical MR machine costs a couple $1 million, right? And then the operating costs are pretty heavy, right? You have to have service contract, the space, the real estate, the techs, the nurses, all of that is pretty expensive. And then there's also the professional side, right? So the interpreting fees, and it takes longer to interpret an MR than it does an X-ray. So a lot of that adds to the cost. And then part of it too is that for most people, you can, even if you go in and you demand an MR as the first thing, and it gets ordered, your insurance won't authorize it, right? So they will demand that you get an X-ray or some other modality first. And X-rays don't require insurance pre-auth, right? So for us, in order to do an MR, we first need an exam ordered, and then it gets authorized, and then it gets scheduled. For the most part, except for when T2 shuffling is involved. So that we have our one exception in our system where we don't actually require pre-authorization for insurance.
But that's very unique to your institution.
Very unique, yeah. So we have like a special carve-out deal for that. But yeah, I think it's it's the time, it's just the insurance mechanisms.
All right, well, let's thank Shreyas, for giving us this wonderful presentation. Really appreciate that, and I wish I could have taken you to Japanese, but maybe some other time.
Thanks. That's great to see, folks. Thank you for inviting me.
Yeah, thank you, and see y'all after midterm 2. So next week. All right.
Thank you.
Bye-bye.
Okay, bye.
Recording has stopped.